Hello, everyone, and welcome to the Real, the Raw, the Mental Health Continuum. My name is Katie Kirby, and I am an adult with CF. I'll be moderating this session this evening, and I'll be introducing all of our speakers here in just a moment. But before we get started, just wanted to cover some housekeeping with the technology for tonight. So the session is being recorded and will be available to all registrants after the event on the CF Foundation YouTube channel. You'll be notified by email when session recordings are available. Also, closed captioning is available. You can turn them on by moving your mouse over the video feed and clicking the CC icon that will pop up at the bottom of the screen. Under the Stage tab on the right side of your screen, you'll notice the chat for everyone who is in this session. If you're in the Event tab chat, that is for the full event and not specific to this session. So be sure you're in the correct chat so that you can engage with others in this session. We will be taking audience questions during the session. So we really encourage you to submit any questions you might have in the Q&A box. You can find the Q&A by making sure you are in the Stage tab on the right side of your screen and then selecting Q&A. We'll do our best to answer as many questions as possible. You can also like any of the questions submitted in the Q&A by others so that we can prioritize those questions that are most popular. Make sure you use the Q&A box to submit questions, not the group chat where questions might be missed. We won't be able to answer any questions about individual diagnoses or treatment plans, and we really encourage you to use the information you learned today to start those conversations with your care team. If you have any technology problems during the session, please click on the help desk icon on the left side of your screen. CF Foundation IT support are there to help you if you have any trouble during the event. So now with all that out of the way, let's get on to our session. I'm so grateful to be joined today by Lisa Scher, a psychiatrist from Stanford, Kathy Cooney, a social worker from Rhode Island Hospital, Laura Tillman, an adult living with CF, and Tonya Hamilton, a parent of an adult with CF. Today's session will be a discussion. We'll cover some of the recent research that has been done and evidence-based therapies to manage mental health diagnoses. But we'll also talk about the many different ways that people experience mental health and wellness. And with all of that, I'm so excited to really kick off our discussion tonight by sharing my story about living with CF and how that's impacted my mental health. So, like I said, I'm an adult with CF, but I'm also a licensed clinical social worker. So, this topic is near and dear to me. I was diagnosed at age 2.5 with CF, and I currently live in St. Louis, Missouri with my husband and our two wonderful miniature dachshunds. I think I really started to notice that CF was impacting my mental health when I was starting to approach a lot of life transitions. In 2017, I met my now husband and started graduate school. By 2019, I was preparing to graduate with my master's, launch my career as a clinical social worker, planning my wedding, navigating some health changes and dips, and then towards the end of 2019, starting Trikafta. During that time, I was still doing everything I needed to do in my day to day life, but I started to notice that it was sometimes hard and exhausting to navigate so many life challenges all at one time. I found I was a little bit more irritable, a little bit more anxious, and it felt a little less in control of my emotions. And my typical coping skills just weren't as effective as they usually had been. Even with being part of the mental health field, I noticed that I was falling prey to some of those myths about therapy. I felt like I wasn't feeling badly enough to need therapy. I knew I had family and friends that I could talk to. I even convinced myself that I probably wouldn't learn anything from a therapist because I knew everything from grad school. I don't really remember what that exact last thing was that caused me to really look for a therapist, but eventually I did reach out to the counseling center on campus, and it wasn't a great experience. I talked about CF and some of the other life transitions I was going through in that first session. I didn't feel like the therapist really understood, and some of her questions about CF were unhelpful. I left that session not feeling better, and in fact, maybe feeling worse. I debated if I should go back or just give up, and my husband really convinced me that I should look for a different therapist. So with the help of talking to friends and family and looking online, I found a therapist who specializes in working with people with chronic illnesses. and I found a fantastic therapist. And with that experience, I found I loved the therapy room just as much from the client's perspective as I do from the therapist's perspective. Throughout so many life transitions, having the time and the space to reflect on how I was doing and what I needed was so helpful. Sometimes we talked about the mundane, everyday stressors I was navigating, and sometimes we talked about my larger existential anxieties for the future. But no matter the topic we discussed, my therapist listened, made me feel understood, and supported me in remembering my strengths that I had lost sight of during those transitions. It was also so helpful to be working with a therapist while starting Trikafta. I felt hyper vigilant about what was happening in my body as I started the new medication, and she was really helpful in supporting me to continue to be aware of what was happening inside my body while also not getting lost or overwhelmed in it. Most of the time, the things I talked about in session with my therapist were things that I would also talk about with family and friends. It still felt different though, because in the therapy room, I could say exactly what I wanted to say without thinking about how it might impact the other person. Talking about CF with family and friends can be hard at times because I know they share a lot of the same concerns and worries I have. My therapist didn't have those same concerns and worries, though. I know and I trust that she wanted the best for me and wanted me to feel good and feel healthy. But talking to her about that gave me the freedom to just be completely honest without worrying about how my worries would impact the other person. As someone who prides myself on always being there for others, it was so meaningful to have a space that was all about me. It helped me get back to my grounded, confident self so I could fully show up for those next chapters of my life, including as a clinical social worker and diving into the mental health field. And so, with that, I'm so excited to hear about the latest research on mental health and CF. And so, I'd like to turn it over to Dr. Lisa Scher, psychiatrist and researcher at Stanford. Lisa will share about the prevalence of mental health issues in the CF community and what we know about some of the clinical approaches to mental health.
Well, thank you so much, Katie, for your introduction and for sharing with us your wonderful story. I'm a clinical associate professor at Stanford, and I've been working with people with CF and their families for the last 10 years, and it's really been an honor. And I'm excited to discuss with you some of the latest research and some of the tools that is available to the CF community. Great. Okay, next slide, please. I will be talking about the continuum of mental health and illness today. And besides being sponsored as a part of the Multi-Site Foundation for the CFCBT study that I will be talking a little bit about it, I have no disclosures. All right, great. Next slide, please. So, of course, I'm going to start my talk with the Great TIDES study. As we know, TIDES is an international depression epidemiological study of over 100 CF centers in 9 countries, including US and Europe, evaluating over 6,000 people with CF and over 4,000 of their parents. TIDES study has been instrumental for us, for the community, really understanding and highlighting the increased rate of depression and anxiety in both adolescents and adults living with CF, as well as their caregivers. And it highlighted this need and helped us to really introduce some of resources. Kind of really, we've always had amazing social workers in the centers, but it really has allowed us to place mental health coordinators into the CF centers across the U.S. We know that significant depression is present in approximately 10% of adolescents, 20% of adults living with CF, 37% of mothers, and a third of fathers. Anxiety is even more prevalent, being significant in 22% of adolescents, a third of adults, almost half of the mothers, and a third of fathers. And these elevations are 2 to 3 times higher than what we usually would measure as depression and anxiety in the community samples. Not only, of course, the psychological symptoms are distressing and can decrease quality of life, we know that they also are associated with medical outcomes. They decrease pulmonary function in people with CF. They increase the risk of hospitalizations. They increase the healthcare costs, of course, affect quality of life, and also potentially tied to a shorter lifespan. All right, next slide, please. And in addition to depression and anxiety, we're now learning about other mental health disorders that can also be more prevalent in people with CF. For example, attention deficit hyperactivity disorder, or for short ADHD, it is more prevalent with people with CF. Across several studies, including study looking at the patients from Israel and Spain, a US center study, and a study in Turkey, approximately 15 up to 22% of adolescents and adults with CF have ADHD. And this is roughly 2.5 times higher than, again, in community samples. And what we know is that ADHD is prevalent in adolescents, and it might even rise with age, which is a little bit different than what we see in the kind of other community samples, where ADHD either remains the same as people age or might decrease a little bit. We know that while in the small studies, it does not seem that ADHD does correlate with decreased FEV function or decreased BMI due to small samples, it does seem it might affect adherence negatively to complicated CF treatments. Why people with CF potentially have a higher prevalence of ADHD? There might be multiple reasons. There might be, genetic predisposition, right? So the risk for CF and the risk for ADHD might be shared. We know that CFTR gene is expressed in neurons in the brain. We're not yet completely sure about its function, but we do know that it might regulate some sleep centers in the brain. There are, of course, life stressors, right? And health stressors are elevated in people with CF. So it might be that this burden brings out ADHD, right? It's more likely to bring out ADHD as compared to somebody who does not share the same struggles. It also might be due to chronic inflammation. Due to bacterial and viral and other infections, there's increased inflammation in the body that, of course, also affects the brain. And we know that many psychological conditions are actually mediated by this inflammation. And it might also explain why we see increased rate of ADHD as people with CF age, potentially. Next slide, please. But what I also want to talk about is the other sides of ties. We know about these prevalences of depression, anxiety. We're learning about mood disorders and ADHD in people with CF. But majority of people with CF do not have a clinically diagnosable depression and anxiety. People with CF are resilient, whether or not they have diagnosable mental health conditions. So if we look and highlight the other sides of ties, we kind of really want to focus on that 90% of adolescents do not have significant depression. Neither do 80% of adults living with CF, 60% of their moms, or 69% of their fathers. And same is true for anxiety. Majority of people with CF, adolescents or adults, and the mothers and fathers do not have clinically significant depression and anxiety. But it does not mean that they do not have stressors and psychological reactions and feelings and emotions and behaviors that do not deserve mental health attention and mental health help if needed. Next slide, please. So I would like to really for us to think about not in terms of black and white mental illness or mental wellness. I want us to get out of this, what we would call in cognitive behavioral therapy, all the non-cognitive distortion, but really think about mental health well-being as a continuum. And we all are on this continuum. At some times of our life, we're more likely to be in one zone, and we might shift, right? And some of us are more likely to occupy one zone more frequently than others. So some of us, hopefully at some point, experience the state of emotional well-being and balance when we feel content with ourselves, with our community, with the world around us, and feel really well overall. And then at other times, many times, there's distress due to life challenges and transitions. That's probably where most of us are every day of our lives. And we have emotions and we have behaviors and thoughts in response to what's happening within us and around us. And it might be distressing. Then some of us might progress to some subclinical symptoms. So there are some symptoms of depression and anxiety, but they do not yet meet criteria for really those diagnosable mental health disorders. And then some of us at some point will meet criteria for diagnosable mental health disorders, as illustrated by the TIDE study. And for example, on PHQ-9 and GAD-7, the tools that we use to screen for depression and anxiety across the US CF centers, right, these people likely will fall somewhere between moderate and severe range. And some of us will have severe mental illness. Really, this is where it's obvious, where people really need help. They might even need psychiatric hospitalization. But all of us and people in general, this continuum, it's not all or nothing. And along each of this continuum, including emotional well-being and balance, we can always, make our mental well-being better if that's what we desire, right? And we can always have access to a variety of mental health tools. Next slide, please. So what are these mental health tools that apparently can be used actually across all of these phases? There are a variety of behavioral mental health tools that can really be helpful, whether you feel content, you have some distress, you have some clinical symptoms, or severe symptoms of depression and anxiety. Exercise and diet can be helpful, relaxation practices, things like guided imagery, for example, or progressive muscle relaxation. Reading can bring a great joy, and we can learn from that. That's my tool of self-care. Spirituality can be important to many people. Creativity, right? Doing arts and crafts, or painting, or writing, or creating music, doing charitable work, meaning making out of everyday experiences. So all of this, a variety of behavioral tools can be very important to support our mental health. And of course, there's also connectedness and community, peer support, what we're doing in a way right here with the ResearchCon, spiritual support, family and friends support, therapy, and we will talk more about it later. And then also Kathy will expand on some of the therapy interventions that are available, and medications. And I want to say that medications can be helpful potentially not only when somebody really struggles with severe depression and anxiety, when the person has some symptoms, but they are distressing and they're wondering if the medication can be helpful for them, talk to your provider. Medication can be the right intervention for you. So don't hesitate to ask your provider whether or not medication support might be something that's helpful, even if it doesn't seem that you score in severe range in PHQ-9 and GET-7, because often we actually want to prevent somebody going into that phase. Next slide, please. So if we talk about the medications, we know that CF Foundation guidelines recommend initially treating a person with selective serotonin reuptake inhibitors, SSRIs for short, medications such as fluoxetine, sertraline, citalopram, or escitalopram, when we're talking about moderate to severe depression and anxiety. SSRIs are good for both depression and anxiety. And to be honest, frequently depression and anxiety are actually coexistent, and often people have symptoms of both. It does take 2 to 8 weeks on the right dose for full effect, right? So unfortunately, with this medication, sometimes you might have a bit of the side effects initially, and they pass, but the good effects, they take some time. So it's important to kind of stick to your medication and work closely with your provider. We usually start at a low dose, and usually not on an empty stomach to avoid the side effects, and then we increase the dose as a person tolerates the medication. Some of the initial side effects are the GI side effects, but again, they should be reversible within 5 to 7 days. And usually I would warn my patients about that so they're not surprised. Longer term, people can have sexual side effects, but again, those are reversible. So if that's something that comes up for you, talk to your provider. And there are many strategies to minimize those side effects if they're burdensome. Some other medications that can be considered belong to different classes. For example, mirtazapine, which is also good for depression and anxiety. It acts differently from SSRIs, but it can also be helpful for appetite, weight, and nausea, especially before Trikafta, when it was harder for many people to gain weight. Appetite and weight was really kind of something important that I would like to target with mirtazapine. It also has fewer sexual side effects. And there's something that we talk about serotonergic toxicity, right? This is how SSRIs act. And some other medicines can also increase brain serotonin. So mirtazapine, if there is something that your provider is concerned about, they can consider mirtazapine as there is less risk of that side effect. Bupropion, yet another antidepressant, is especially good for motivation and energy, and it also has fewer sexual side effects. Yet another class, serotonin norepinephrine reuptake inhibitors, which includes medications such as duloxetine and venlafaxine, are also helpful for depression and anxiety. And pretty much everything that applies to SSRIs also applies to SNRIs. They might be a little bit more effective and can also be helpful for what we call comorbid neuropathic pain. Really just means, for example, somebody has diabetes or some other process, and there's a nerve-related chronic pain. It can be also targeted by these medications. Next slide, please. And sometimes the questions comes up, right, and people are worried about either using these medications, or there's a question about do CFTR modulators increase the risk of depression, anxiety, or energy side effects, or cause insomnia or cognitive side effects? I know there's a lot of talk within the community. I want to say that clinically, what we see on the research side, there's only a few cases that have been reported, but we definitely are listening and studying, and this is something that we do need to study more. If potentially somebody, let's say, has history of depression and anxiety, maybe they treat it with medication, maybe not, and they've been started on CFTR modulators such as Trikafta, and they have worsening of their depression, anxiety, or those symptoms appear for the first time. There might be actually multiple reasons why that's the case. There might be drug-drug interactions, right? So, for example, somebody's on a medication antidepressant, and then CFTR modulator decreases the amount of the medication that is actually in the bloodstream. So that can be a possibility. There can be potentially effect on CFTR functioning. As I mentioned, we know that CFTR gene is in the brain, it's expressed. We're not exactly sure the complete functioning of it. It also might be due to improvement in physical status, even though the outlook is better, people are feeling better, they have more energy, but maybe they're not sleeping more, right? Or there might be more psychological and existential concerns now that there's a longer life around right ahead of them and there are more choices to be made. So there might be a variety of reasons why people might develop depression and anxiety, if they do. But again, I want to assure you that what we see in the research side, we know that there's, for example, a case series for patients by Dr. Tywakar and Georgopoulos, that when they published their report on 4 patients who have developed depression and anxiety in the context of CFTR modulator use. In Stanford clinical experience, sort of the significant cases that have come to mind, we've had one patient who developed depression when they started Trikafta, but it resolved after we treated the person with an SSRI, and now they're benefiting from both and doing really well. There's also a case of a patient who's on the mood stabilizers, sort of a different class of medications. And when different CFTR modulators were introduced, it definitely affected the levels of the mood stabilizers. And we had to change and adjust the doses. But again, we also found the right solution for that patient as well. As already is being done in CF centers across the US, close mental health monitoring should be established in people with CF. And hopefully, if you do have concerns about starting CFTR modulators, definitely talk to your providers about this. If these symptoms do appear, we can definitely address them. So what are some other ways, of course, of treating depression and anxiety is with variety of therapies. And I want to highlight that especially if somebody has moderate to severe depression and anxiety, it's really the combination of medications and therapy that has shown the most benefit. There are a variety of therapies available. And I think the most important factor of how well you will do with therapy, it's actually your connection with the therapist. I think, so Katie sort of referred to that, how she found the person that she resonated with. Kathy will also talk later about how to find the right provider for you. But just some of the different orientations of the therapist are CBT. We hear a lot about it these days, which stands for cognitive behavioral therapy, where we really think about how our thoughts and feelings and behaviors are all connected and how we can change some of this to have overall better quality of life. There's acceptance commitment therapy, which really focuses on accepting kind of the current reality and then making choices based on your values in life and your goals. Dialectical behavioral therapy, or DBT, can be really helpful for example, mindfulness or distress tolerance. Interpersonal therapy looks at changes in roles and relationships. Existential therapy, I'm a big fan of that, right? Looks at kind of existential threats, including mortality. And psychodynamic therapy can look at how our past defines and shapes our present. Most therapists use a modality of these techniques. So usually you're not going to have a therapist who is completely subscribed to one school of thought. Although there are therapists who, for example, are only CBT, but usually it's really going to be a combination, and they're going to use different skills based on what is needed for you. The exciting news in the CF community is that now there are studies undergoing for looking at effectiveness of cognitive behavioral therapy as well as ACT, but I'm not going to talk much about this, specifically for people with CF. We know that CBT has been studied in sort of medically healthy populations, in other medically ill populations, for example, people with cancer and HIV and AIDS, and now a group from MGH, my colleagues, Dr. Deborah Friedman and Dr. Anna Georgopoulos, have started this study. The initial pilot study enrolled 14 participants across 3 CF centers, and they have designed this 8-session manualized CF-specific CBT, which is really exciting. Majority of the patients in the pilot study, 13 people, have finished all the sessions. They reported a really great engagement, and they liked the session. There were no adverse side effects. People really seemed to like it. And really, what this pilot study showed is that such a study is possible because this was done within the CF centers, right? And intervention was done by people who work within CF centers, social workers or psychologists, but potentially can be done by any member on the team who's interested and has training. This intervention is possible, and people with CF are excited about this. So next slide, please. How has this been evolving? We know that now there's been a study on eHealth CFCBT, for example, in a Dutch center, where they've taken this work by our great MGH colleagues and they adapted this to internet-style intervention, where kind of online modules and direct working with the provider have been combined. 16 patients have gone through this intervention, and also this program has been very well received, and now they're using this program to strengthen overall the care, both mental and medical aspects of CF care. And now we actually are in the middle of in the US, of the CF-CBT randomized control trial in adults with CF study. And I'm happy to share that Stanford is one of those 4 sites, with MGH being the lead site. We have enrolled 60 patients with mild symptoms of depression and or anxiety, and patients were randomized to either receiving those 8 sessions right away or waiting for 3 months and then receiving those sessions. And here, kind of on this busy slide, you can sort of see the breakdown of those sessions, what we have focused on, but really each session has gone really quickly, focusing on a particular CBT skill. And a variety of providers, right, interventionalists have been involved in this, psychiatrists, psychologists, social workers. We even had the pulmonologist, actually, who's had therapy who administered therapy to some of their patients. And overall, we're still in evaluation of the results, but it's exciting, and the results are very promising. So what's next? Again, the MGH are now going straight ahead and piloting a study of CF-specific CBT in adolescents with symptoms of depression and anxiety, and that's ongoing, and hopefully we'll hear about soon. And also now we're discussing about, as we're analyzing the results from the 60-person randomized controlled trial, we're talking about how can we implement the CF-CBT in the centers across the US, and that discussion is ongoing, and you might just see this soon in centers around you. Next slide. So this concludes my portion of the talk, and looking forward to some of the questions that will come up for us. And I'm very happy to introduce Laura, who really beautifully represents the other side of tides.
Thank you, Dr. Scher. I'm Laura Tillman, and I live in Northville, Michigan. And unlike the majority of CF patients, I was diagnosed at the age of 47. So I was pretty comfortable in my skin and didn't have to go through all of the different things of growing older while CF was hanging over my head. My diagnosis neither surprised nor brought relief, as I already knew I had CF by the time I received my definitive diagnosis. That diagnosis just confirmed all of the research I'd done when CF was brought up after sinus surgery. And treatment, I was already receiving treatments for my symptoms, so the diagnosis didn't really provide a lot of difference in what was going on with my life. My husband and I share a philosophy that whatever comes our way, we just deal with it. And that's what we did with CF. But that's not to say that it didn't change our lives, because it did. While I continued to work for the next 5 years, all spontaneity was gone from our lives, since I had an hour's commute to work and I had to fit in my morning treatment, which required going to bed earlier so I could get up at least an hour earlier for the treatments. And when I was on IVs, even more time was needed, which was a hardship until I finally decided that working in IVs just didn't go well together. It also meant that I didn't do errands or go to appointments or just hang out with friends and go to dinner after work. I had to come straight home to get dinner ready, read the mail, do treatments, and make sure that everything was ready for the next day. I also lost some of my independence, as back when I was diagnosed, there were no vests. So my husband had to help me with airway clearance by doing clapping. Weekends also were less fun as we needed to accomplish all the tasks that didn't get completed during the week. So my life did change, but we just had to carry on, as the English say. I tend to use humor to look for the positives, and I have a great ability to compartmentalize. So CF was put in a compartment in my brain, and I went about my day until I had to take CF out of its compartment and deal with it. As far as humor, my doctor and I had a running joke whenever CF flared up. I told him that the aliens from outer space had abducted me and that this was really all just a psychological experiment that they were running on me to see where my breaking point would be. But I fooled them. I didn't break. And one time, after a long and weary hospitalization, I was seeing my doctor for a follow-up appointment. He handed me a sheet of paper regarding one of the bacteria that I had cultured. The very first sentence stated that it was commonly found in hedgehogs. So that became another running joke. Then there was the time a friend called me on a Saturday shortly after my diagnosis, and my husband told her I was getting my nails done. When I returned her call, she asked, "How can you even think of getting a manicure when you're suffering from this disease?" I told her that if I was going to be burdened with CF, I was going to do everything possible to look damn good, no matter what. Doing things to take care of myself is a normal part of my day and my life, and normalization is critical to my well-being. On the positive side, and this isn't going to sound so positive, I had an arm port. But the positive is that my fur baby at the time was used to seeing my IV pole with bags hanging from it, as well as needles. During his last summer with us, he needed sub-Q fluids. He was so accustomed to seeing my equipment that he accepted the procedure with no problems. Just laid there and let me do what was needed. For me, the hardest part of CF actually has been my survivor's guilt. I've outlived so many others, both with and without CF. I suppose there's a reason for that, and I'll find out soon enough. But once again, I go through my period of mourning, I compartmentalize, and then I carry on. And I also had to retire early, which admittedly was disconcerting. But I soon discovered that CF gave me a direction and sense of purpose for my retirement, as I became involved with a number of different CF organizations. And as strange as this may sound, CF has also brought a great deal of gratitude into my life because I have met so very many wonderful people who have become dear friends. So I tend to be on the other side of tides and try to just carry on and deal with whatever life throws my way. And now that you've heard my side, Kathy Cooney, our resident social worker, is going to offer some suggestions that may be helpful wherever you find yourself on this mental health continuum.
Thank you, Laura. Thank you for sharing your experience, especially some of the ways you overcame challenges you faced with a late diagnosis of CF. I have to say, it has truly been a privilege to work with resilient people like you and Katie over the past 15 years as a clinical social worker and mental health provider with our pediatric and adult CF programs. Well, hopefully after hearing from Katie and Laura with different experiences living with CF, this idea of a continuum of mental health and well-being that Dr. Scher talked about is making a bit of sense. When we were planning this session, we wanted to really highlight that mental health is not something that a person has or doesn't have, and that working with a mental health provider can be helpful not only for significant challenges, but also for periods of adjustment like Katie described. So I'm going to share a bit about what is meant by well-being and offer some strategies that might be helpful. I also hope to offer some ways to be informed, to be an informed consumer of mental health care. Next slide. I have no disclosures. Next slide. So before I begin, I think it's important to acknowledge that although everyone listening today is impacted by CF, whether as an adult or a parent of someone with CF, each person also has unique experiences and perspectives. Some adults may be new to adulthood, and some may have been doing this adulting for a good long while. The caregivers may be single parents, co-parents, grandparents, foster parents. And then those caregivers might be caring for an infant, a young child, or a teen, each with their own unique situation. And of course, then there are factors such as gender, cultural, and racial diversity, as well as whether a person is working and what kind of work, what kind of financial means they may have or not have. And as you know, there are differences in living with CF, whether you or your loved one is eligible for modulator therapy, whether you're pancreatic sufficient or insufficient, or whether you're living with CF-related diabetes. Next slide, please. As we talk about mental health and well-being, and particularly possible strategies for improving our mental health, I want to highlight that what might be helpful to one person may not be particularly helpful to someone else. And if you're a parent or a caregiver to a child or adolescent, believe it or not, applying some of these strategies to yourself will likely have a positive impact on your child. All of this is why working with a mental health provider can be so helpful. They can work to understand your unique experiences and perspective and find strategies that work for you. My hope is that you will find a little seed in what I share that you can apply in a meaningful way to your life and your unique experience. Next slide, please. So as you heard from Dr. Scher, the TIDE study showed that people with CF and caregivers of those with CF are at higher risk of having episodes of depression and significant anxiety. But I want to take a moment to think about what might be helpful when maybe a person doesn't feel like depression or anxiety is a significant problem. And yet it feels like life could be just a little bit less stressful, a little bit more enjoyable. Well-being is a term used by the World Health Organization and encompasses mental health. It refers to several domains that contribute to an overall sense of satisfaction with life, a higher degree of quality of life. The internal domains include emotional, intellectual, physical, and spiritual, and the external domains are social, occupational, environmental, and financial. And of course, all of these domains can be certainly impacted by living with CF. Next slide. So exactly how does one cultivate well-being? You will see that I really love this word cultivating. To me, it means growing, like growing a garden. If you've ever had a garden or a plant even, you know it's not that you either have a garden or you don't have a garden, or you have an amazing garden free of weeds and full of flowers. You really have to work at it. You have to cultivate it, help it to grow. And well-being is like that. It's not something people have and others don't. It's not completely dictated by circumstances. In my work with people with CF, I have seen firsthand that it is possible, sometimes not easy, but it is possible to find quality of life in the midst of significant challenges. It's like if you have a garden, you can't change the climate or the amount of rainfall, but you can pick the weeds, water regularly, and cut back to help the garden flourish. Same with cultivating well-being. And in this illustration, our values are like the soil, and each circle is like a seed. And each of these seeds is connected to the other. Our thoughts, our emotions, our connections or relationships, and our habits or our behaviors. And like I said earlier, your situation is unique, and which seed needs attention, only you know. These are just a few that might be worth considering. Next slide, please. So as I said, our values are like the soil. So what do I mean by values? Well, it can be a little tricky, but basically they reflect what really matters to you. What sort of a person do you want to be? What do you want to stand for? Sometimes it can be kind of hard to put into words. But one useful way to use these values is to recognize that every day is filled with choices that either move us toward or away from being that person we want to be, from living a life that reflects our values. Once we have a little clarity about what's really important to us, it can guide our actions and behaviors. Next slide, please. So one aspect or seed of well-being is being aware of our thoughts, or that inner voice, that constant voice that's usually talking about the past or the future, or judging ourselves, or maybe judging others. Most people know they have an inner critic, but it takes some practice to really know when that inner critic is getting loud and not very helpful. Noticing the inner critic may not make them go away, but it can certainly turn the volume down so you can challenge their negative messages. I was feeling quite nervous about this talk, and when I paid attention, I caught my inner critic saying, "You're a terrible speaker. You're going to embarrass yourself." Well, once I noticed this, I was still a bit nervous, but I was able to remind myself that I've actually done a few talks before, and usually I get some good feedback. So another way negative thoughts show up is something called negativity bias. 10 good things could happen in a day, but at the end of the day, we focus on the one thing that went wrong. Again, just being aware of this bias can begin to change your focus. That bad stuff might still be there, but can the good stuff get a little more attention? And lastly, most of the time, it is human nature to operate on automatic pilot, oblivious to the thoughts and emotions that are coming up through the day. But if we can develop an awareness of thoughts as they arise, it allows the process to slow down so we can respond instead of react. Speak or act in a way that maybe is more in line with our values. Next slide, please. The challenge is that awareness of our thoughts does not usually come naturally. It's one of those things we can't just do. We actually have to cultivate. Being aware of our thoughts is not a switch we can turn on. It's a skill that has to be developed. It's a mental muscle, and just like when physical muscles are weak, they can be developed through lifting weights many times. Developing awareness requires practice. So like taking 10 or 15 minutes a day, finding a quiet spot, or going for a walk. You can even practice while folding the laundry. And notice what you're seeing, maybe what you're hearing, maybe the sensations in your hands or your feet. And of course, then just noticing thoughts as they come and go. And yes, you could also call this mindfulness practice. Most people think of mindfulness practice as a strategy for calming or relaxing, but it's actually a really good tool for cultivating awareness of our thoughts. So maybe we can have more choice in which thoughts we embrace and which ones we kick to the curb. Next slide, please. Another seed is emotion, or our emotional landscape. I love that term, emotional landscape. I got that term from Katie, and I think it really fits in this area. Cultivating emotional well-being does not mean cultivating only the good emotions and weeding out the bad. All emotions are normal and useful at times. Anger, sadness, joy, happiness, frustration. It's really about cultivating not only awareness of emotions as they arise, but sometimes learning to accept them or simply be with them. When it comes to difficult feelings or emotions, we tend to seek ways to avoid them. Food, Instagram, my personal favorite, or emotions, or YouTube, or maybe even an extra glass of wine. The problem is not only do avoidant behaviors move us away from living by our values, but avoiding painful emotions doesn't usually work long term. And of course, there are times when it can be helpful to cultivate positive emotions for a little bit of balance. Emmons and McCullough did a series of studies and found that those that were assigned to keep a list of what they were grateful for exhibited heightened well-being across several of the outcome measures. It can also be helpful to be intentional about being kind, both to others and to yourself. One study found that several acts of kindness in one day resulted in an increased sense of well-being. I'm sure you are all pretty kind and nice, but we can all get caught up in the weight of our day. So it doesn't hurt to be intentional when it comes to kindness. Next slide, please. Another seed in the garden of well-being is connection, social connection. Studies have shown that social connection or support, both perceived and actual, have been shown to be protective against stress and depression. Cultivating connection involves being intentional with our current relationships and maybe even making new connections. Of course, when I mention social connection, social media comes to mind. And for some, social media can give a bit of a false sense of social connection. But for many, especially those living with CF, this is a very important way of connecting with others. As with all of these seeds, only you can decide the degree to which social media leaves a feeling of support and connection or a feeling of distance and that feeling not good enough. Some additional ways to build connection with the CF community are, of course, through events like this one, and also CF Voice and even CF Peer Connect. Next slide, please. And finally, the seed of our habits or behaviors. The good news is we can develop new habits, especially when our values guide us, and we're paying attention and not running on automatic pilot. One area it's easy to develop unhelpful habits is digital media. This is different from connecting to social media. It's the dreaded scrolling habit. Most people these days do this to some degree. If you've seen the film Social Dilemma, you know that these apps were designed to be habitual and not for our benefit. That knowledge alone might help you to change these habits. Sleep and eating are other areas we can develop not so helpful habits. If you do see a habitual behavior that isn't moving you towards your values, consider making a small change. But be sure you know why you want to make it. Is it because someone else thinks it's important, or is it really important to you? And the last area I'll call activity. Physical activity has been shown to be beneficial for mental health and well-being. And there are so many ways to be active: short walks, yoga, Tai Chi, karate, and maybe most important when considering habits, work on just one thing at a time. Finally, I want to point out that sometimes it can be quite challenging to try new approaches or ways of being in the world. And this is where a mental health provider might be really helpful. Next slide, please. So when considering working with a mental health provider, please remember that mental health treatment is effective, but it's not usually a quick fix. Weekly sessions for 6 to 12 weeks is usually necessary for lasting effect. It's also important that after a couple of sessions, to make sure that you're comfortable with the provider. When it comes to mental health treatment, trust in the provider is essential. And there are lots of different approaches to therapy, as Dr. Scher mentioned, so finding the one that's a good fit for you is also important. I really think Katie gave a great example of the value of shopping around. Next slide, please. So the term often used for mental health treatment is psychotherapy, and it can be provided by a number of different types of professionals, including psychiatrists, licensed mental health counselors, licensed marriage and family therapists, psychologists, licensed clinical social workers, nurse practitioners, and I think there are actually a few more. So psychiatrists and nurse practitioners are also able to prescribe medication. Next slide. Sometimes it can be hard to know if mental health treatment is really needed or will really help. So a couple of things to keep in mind. If your mood or anxiety are really getting in the way of basic things like sleeping, eating regularly, getting to work or school, or being with the people you care about, please consider seeking treatment. If you're feeling completely alone, feeling worthless or hopeless, please let your CF care team know. Mental health treatment can really help. And I know your care team is very eager to help you. This is a list of symptoms that might suggest a person would benefit from treatment. You know, I often hear people say they tried therapy or medication and it just didn't work. But then they'll go on to say that they only went to see the therapist a couple of times and they actually didn't take the medication as it was prescribed. As Dr. Scher said, some medications have to be taken every day to really be effective, and then the dose might actually have to be changed. So if you feel like treatment didn't work, I really encourage you to consider trying it again. Next slide. And if you're not sure where to start, there are a few options. As I said, one is your care team. You should have a social worker or a mental health coordinator, but it doesn't have to be them. It could be anyone on your care team. And I know they will be happy to help you find treatment. Another option is your primary care doctor. They can also help you sort out if treatment would be helpful. And in fact, many PCPs will prescribe SSRIs, the class of medication that Dr. Scher mentioned. And lastly, since for many, I know reaching out can be really hard, especially when suffering, there is the Suicide Prevention Hotline. They have a clinician available 24 hours a day. Next slide, please. So I hope some of this information has been helpful. And if you'd like to learn more on your own about these strategies, here are a few suggestions. I do just want to say that none of these are intended to replace treatment for clinical depression or significant anxiety. So Coursera and edX are websites that offer free educational opportunities, and both have free online courses covering the basics for cultivating well-being. And Healthy Minds is an app developed by researchers at University of Wisconsin that teaches what they call the 4 pillars of well-being, and it's also free. And if you're interested in mindfulness, I highly recommend taking the MBSR Mindfulness-Based Stress Reduction class. And really the best way to find that is to just Google MBSR in your area. And then lastly, there's a great workbook, Get Out of Your Mind and Into Your Life, that's based on acceptance commitment therapy, and I highly recommend it. So now I'd like to hand off to Tanya, a parent of a young adult with CF, to share a little of her journey with mental health as a parent.
Thank you, Kathy. That information was so amazing. And I personally am very glad that this session is going to be available later on YouTube, because I'm going to go back and I'm going to watch it maybe a couple of times. My name is Tanya Hamilton. I live with my family in Michigan, and I am the mother of 2 young adults. My oldest is my son, who is living with CF, and I also have a daughter who is a carrier. Thank you for allowing me to participate in this conversation this evening. So I'm probably the shining example of how not to manage your mental health while raising a child with CF. And that's because I really didn't manage it at all. My son was born in the late 1990s and was diagnosed at 2 months of age. Sadly, my mother had passed away just 2 days before he was born. So as a new young mom holding a baby with cystic fibrosis, I felt, my perception was that I had to make a very quick decision of whether I was going to crumble or whether I was going to carry on. And I chose to carry on. But the problem was that in my mind, carrying on just meant that I wanted or needed to control as much as I possibly could. It meant spending countless hours educating myself so I could best care for my child and become a competent member of his care team. I wanted to be able to understand all of the lingo and know all of the right questions to ask his doctors. And don't get me wrong, education is extremely important. But my favorite motto became knowledge is power. And what that really meant in my head was knowledge is control. I spent all of my time trying to control our situation. And so I suppressed my emotions to become an amateur CF specialist, which meant I was really taking no time to practice my own self-care or do anything that forced me to face my true feelings. As my son grew older and his disease progressed, the desire to control our situation grew stronger. When his team began to use the word transplant, I began to research different transplant centers and their eligibility criteria. And I began to worry. Would disclosing that I, as a caregiver, or anyone else in our family struggled with anxiety in any way, prevent transplant as an option for him? And then I realized, as the concern grew, I was trying to hide those irrational fears from my family, but was I hiding them well enough? And if not, what effect was that having on my son's health? So our family's coping strategy became humor, and decompressing from a long day at clinic often looked like gathering around the kitchen island with a pizza and a laptop to watch Jimmy Fallon videos. And while humor and a healthy dose of sarcasm could prove helpful, they're also another very easy way to suppress other feelings. And this was another way I allowed myself to forgo real self-care. It wasn't until I began a new job 5 years ago, working for a prevention organization that encourages mental wellness, that I began to realize how lacking I was in my own self-care practices. And at the same time, I began to see a shift in the way CF clinics were handling mental health care as a part of CF care. I started to see more mental health screenings offered to both patients and their caregivers, and I began to notice that social workers were addressing more than just insurance issues or school issues with their families. This was a welcome change, and I hope that we continue to see this. Speaking as a parent caregiver, I think seeing integration of mental health support in CF care will help to prioritize this need. And witnessing pulmonologists and mental health providers collaborate the same way pulmonologists and endocrinologists do, for example, will allow CF families to embrace mental health care as a critical part of maintaining overall health. So if I could turn back the clock to my son's diagnosis, I would recognize that balancing my own mental health should not have been a question of crumble or control. It is a conscious decision to accept that life is a balancing act and that it's okay to not be perfectly balanced all the time. We deserve to care for ourselves the way we so devotedly care for the people we love. And so with that, I believe we've reached the Q&A portion of this session. So we'll have everyone join me back on screen. And as a reminder, all participants were given the opportunity to submit questions for our presenters during registration. So tonight's questions will come from those submissions, as well as questions that have been submitted through the Q&A box this evening. And our first question tonight addresses something I spoke about just a moment ago. How does mental health status impact transplant eligibility? And I think, Dr. Scher, that might be a good question for you.
Well, thank you, Tanya. It's a really good question. And, you know, in terms of when somebody's being evaluated, let's say for lung transplant or liver transplant, there is a whole psychosocial evaluation that is done. Because really, you know, transplant centers want to ensure that people who are receiving transplant really will fully benefit from the transplant and have increased quality of life and prolonged life as well. So mental health in the person who's being evaluated for transplant will be evaluated. But this is not with the purpose to punish them, right? This is really to make sure that if they have depression and anxiety, and we do know that people who present for transplant have increased rates of depression and anxiety, we know that. We want to make sure that they are addressed. We want to make sure that they connect with a therapist or a psychiatrist or other supports as needed. So it's really to make sure that symptoms are as controlled as they can be, that patients are aware of what's going on, and that they're connected. The idea is that we really want to strengthen, right, the candidacy and help the people. In terms of the caregivers, social support is really important for a person to do well after the transplant, and centers require several support people. We want to make sure that support persons are available and functional. And again, if a support person has depression and anxiety, it's not surprising, right? We know that it's common, period, and it's common in people who are taking care of somebody they love who has a medical illness or some other challenge. Again, we just want to make sure when they're evaluating, the evaluators want to make sure that the support person has the resources. So it's not to punish or to exclude, it's to make sure that they're doing okay for now and that they have the right resources.
Looks like we have another question here that may be for you again, Dr. Scher. As a parent who speaks to many other parents, it is more than a few cases of serious mental health side effects with Trikafta. I know a lot of people who have also had to change meds with AM and PM doses. Is this being studied more closely? Can the mental health side effects that are being observed more and more with Trikafta be addressed?
Again, another good question. So I think, that I hear, for example, from people who present to our CF center, right, more reports of potentially more anxiety or depression, right, or difficulties with sleep. And some people do experiment with AM and PM kind of dosing and changing in that. Scientifically, as I understand, we don't really understand why changing the dosing night or morning would make a difference, but people do report that's helpful. It is being looked at more, but of course we need controls, right, to compare somebody who starts Trikafta for somebody who doesn't, and of course somebody who does not Trikafta, right? There are other variables. So it is being looked at. If somebody who starts Trikafta or the other CFTR modulator, and they do have symptoms of depression, anxiety, problems with sleep, talk to your providers. Those symptoms can definitely be treated. And I know that people who have spoken of the side effects, right, whether they're related physiologically or existentially or somehow else, those symptoms can be addressed. Medications can be effective, right? Therapy can be effective. Behavioral interventions can be effective. So, but that's something that definitely, whatever is the etiology and reason and incidence, that's something that can be helped.
We will send to Kathy. Would it be possible to teach children coping strategies as part of clinic visits since they are young, so the mental health burden can be better handled as CF patients get older?
Sorry, I think I was muted.
I think so.
I had such a good answer too. Yes, this is a great question. I definitely think it's possible to teach children coping strategies as part of their clinic visit. I think there may be some challenges depending on the clinic or the CF center. You know, sometimes there's issues with adequate time for all the things that we want to try to do during a center visit. But I would say if a parent is really interested in this, that they should talk to their team and let them know if they feel like that's something they'd like to see happen. Definitely let their team know. And I know for sure that that is happening in some CF centers. But like I said, I think that there are often some logistical barriers to having adequate time during a clinic visit.
Okay, great. All right, next question. When medical issues and medical care become too much, is there a way to take a mental vacation from all of that? Just wanting to leave it all behind and take a fresh breath of air without the responsibilities of keeping my body alive. Meanwhile, it eats at my mental health. Katie, do you have some thoughts on that?
Sure. I'd love to jump in on this one. So something that I do both in my personal life, but also work with clients in my own private practice on is exactly this, a way to kind of just bring in that deep relaxation and that sense of being really carefree, which is immediately what I think of when I think of vacation. And really, I think the best way to do this is to return to a moment and a memory that you have where you felt that way, that you want to really savor that experience. You know, in those moments where we're really just needing that break, what we need is for our emotional brain to have that really felt sense of relaxation. It's not enough to know that we can just take a breath or we can, step away from our treatments for a minute. We really need to feel that sense of ease in our bodies and in our mind. And so my favorite way to do this is just to recall a memory where you had that sense of feeling safe or feeling relaxed or even feeling in awe or wonder of the people or the places you're around, and recalling all of the sensory information that you came from those moments. So for me, I think of a memory with one of my best friends traveling abroad and being in the water and feeling the sun on my body and the water all around me and the laughter and just really focusing on what that all felt like, both inside and out. And that's the way I give myself that mental vacation and just that really deep savoring of a really wonderful time.
And here is another question that maybe Dr. Scherer can take. What is effective for treating our CF-related PTSD? It feels like the treatment options are fighting a fire with a squirt gun. No mention of PTSD or survivor's guilt. That's a great. Whoever's
Such a truly excellent question, right? And of course, the fact that we're not mentioning PTSD highlights. I did not have a mention of PTSD in my slides, right? Something that is important for us to put greater focus on. But we definitely recognize more and more medical PTSD. We talk more and more about PTSD, for example, after transplant. We know that 18% of people after transplant within 2 years actually have a diagnosis of PTSD. And that's similar to survivors, let's say, of natural disasters, right, or war situations. We talk about ICU-related PTSD, and people with CF, without having gone through transplant or ICU stays, also have PTSD due to a variety of medical interventions and existential and physical threats. So that's something that we do talk about in the community, but it's definitely not enough highlighted. But the treatments are there and they're available. It's again going to be a combination of therapy and medications. Medications can be helpful, but therapies, working with a therapist, can be really helpful. And usually a particular type of treatment for PTSD, which is post-traumatic stress disorder, is a particular type of cognitive behavioral therapy, which is exposure kind of a relapse prevention. Of course, it might be hard, right, for example, if coming to clinic is triggering, and yet you need to come to clinic, right, we might not be able to avoid that. So the idea is really to identify those triggers and develop different way of thinking about it, develop relaxation practices, utilize a lot of the techniques that Kathy has spoke about, and potentially also combining it with medication treatment, including SSRIs. But treatment is there. So if you or your loved one is suffering from medical CF-related PTSD, definitely please come forward.
Super. So the next question we have asks, what are the most pressing mental health issues being addressed in the CF community today? And we are actually joined by one of the members of the CF Foundation's Mental Health Advisory Committee this evening. Laura sits on that committee. So Laura, do you have any input? Oh, I think yeah, there we go. We might have to ask you to start over, Laura.
Sorry about that. Yes. In fact, we've done surveys regarding this and have presented that information to the CF Foundation. The surveys we did were sent both to the community and to the providers. So the community consisted of adults with cystic fibrosis and caregivers, and the providers were whoever at clinic filled out the survey. So it could have been the clinician, the social worker, psychologist, respiratory therapist, nurse, whoever. And it was very interesting because there was not much difference between the community members or the providers in the top six areas that were selected. And those were depression and other mood disorders, the effects of mental health conditions on physical health of people with CF, the effects of treatment burden on mental health, understanding risk factors and the prevalence of mental health conditions in people with CF, and the effect of CF on family dynamics. So some of the things we've actually talked about here today. And basically, the conclusion was that the areas that require improvement right now are the access to mental health support, implementing evidence-based interventions through the CF clinic, increasing prevention, which we've talked about, and creating educational materials and resources for community members. So those are all areas that we're looking at working on in the future.
Okay, wonderful. Another question for Dr. Scher. Is there any evidence of an increased incidence of excessive sleepiness, hypersomnolence in CF patients?
A great question. I don't remember studies that I have seen that particularly cite an evidence for this. It does not mean the study is not there. It probably means that I have not really looked for that specifically, and I will definitely look it up and happy to email out the answer more. So I cannot think of papers that cite this, but I can say that clinically, I definitely do see in people that I see with CF who do report, especially pre-CFTR modulators, increased need for sleep, right? Especially sometimes what I see was the decline of the lung function, right? That potentially people need more sleep to have more rest and to rejuvenate and to have more energy. I also see that for many people, when they start CFTR modulators, in particular Trikafta, they need less sleep and they are more energetic as well. So, but it's a great question.
Okay, and it looks like this will probably be our last question for this evening, and one that perhaps several of you can weigh in on. The real world brings stress, and as a full functioning adult, those stresses become more normal and compound with our healthcare responsibilities and work. What are ways you de-stress with the challenges in adulthood?
I have a few ways that I de-stress. One of them actually, though, is a dichotomy because it's a huge stressor in my life while it helps me de-stress. And that's my dog, my senior dog. And it's a stress because I know he doesn't have much time left with us on this earth. But when I'm stressed and I come home and I can sit there and just pet him and have him look at me with those big brown eyes, adoring me, it calms me down and I'm not stressed as much. Another way that I de-stress is, as I said when I was talking, that I'm able to compartmentalize. So I can put that stress in a compartment, and whatever I have to do, I work on and I do, and the stress doesn't interfere whatsoever. And a third way to de-stress for me is reading. Reading relaxes me, reading calms me down, reading takes me out of my own world and into another world. And so I find those three ways are the way I cope the best.
I would say my de-stressing skills are very similar to Laura. Definitely my dogs and reading are some of my top ones. I think also just getting outside when it's really nice, if that's a walk around my neighborhood or sitting in a rocking chair on my front porch, that's a really great way to just kind of take a break for the day and de-stress a bit. And then also just having time with family and friends. One of my favorite roles in life is being an aunt. And so I have lots of little nieces and nephews right now. And so getting to just have fun with them and play whatever imaginative game they have going on, or chasing them around and laughing with them is definitely one of my favorite ways to de-stress.
Great. All right. Well, we want to thank everyone for submitting wonderful questions this evening. And thank you to our panel for all of your thoughtful answers. That does wrap up our Q&A. Katie, would you like to wrap things up for us this evening?
Having some trouble over here with the muting and unmuting, but there we go. So thank you so much to all of our speakers tonight for sharing your knowledge and your insights about the real, the raw, the mental health continuum. And thank you so much to all of our audience members for your attention and your questions. There are many wonderful resources related to this discussion and the resources document found on the reception page. For this session, you'll find the slides we shared and other items the speakers thought you might find valuable. So please spend some time exploring the resources and download anything you would like to keep. In addition to those resources, if you'd like to contribute to research prioritization by sharing your insights in surveys, focus groups, or committees, we encourage you to join Community Voice. Being signed up for Community Voice means that you will receive opportunities that are available in the areas you indicate interest in. So up next, we have the Expo booths and networking sessions open for the next 45 minutes. In the Expo, you can visit CF Foundation staff to learn about several foundation research initiatives, or visit one of 2 Meet the Speaker booths where you can casually interact with Dr. Greg Sawicki and Shelby Lubert from the opening keynote, or Dr. Jay Freeman and Amanda Hively from the GI session, Listen to Your Gut. If you are more interested in meeting other ResearchCon attendees, visit the networking tab, which is a fun feature that allows you to connect with others and get randomly matched with another attendee for a 5-minute video conversation. This attendee could be a clinician, a CF community member, researcher, or CF Foundation staff member. You never know who you might get matched with, and we hope you have some great conversations. After the networking and expo booths, we hope to see you at 12:45 p.m. Eastern Standard Time on Saturday, April 9th for day 2 of ResearchCon. Thanks again for coming tonight to learn about the real, the raw, the mental health continuum. Have a great night.